Hello everyone, my name is Brière. I'm a resident at Laval University and I will be presenting our research project on Fulguration in association with oral Cyclosporine A for the treatment of interstitial cystitis with Hunner's lesion. Thank you to the scientific committee for allowing us to present our results. I have no conflict of interest. Among the ICBPS population, a small subset of 16% present cystoscopic finding of Hunner's lesions. Cyclosporine A is a fifth-line treatment for ICBPS due to a paucity of literature reporting its efficiency and due to potential adverse events. A few studies have demonstrated greater benefit of cyclosporine in HL patients compared to those without lesions. Fulguration is a recommended treatment for ICBPS with HL. However, subsequent procedures are often required as symptoms are likely to reoccur. The objectives of our study were to assess the clinical outcomes of refractory HL patients treated with lesion fulguration in association with cyclosporine A as a maintenance therapy and to assess cyclosporine safety profile. We hypothesized that daily low-dose cyclosporine could allow sustained symptom alleviation while limiting adverse events and therefore decreasing the need for repeated procedures such as repeated fulguration. This was a retrospective observational study of refractory ICBPS patients with HL who all underwent baseline fulguration in association with daily 1.5 mg per kilogram of oral cyclosporine A from April 2015 to March 2021. Dose reduction was conducted in stable patients with prolonged treatments or in the occurrence of adverse events. Data at the last follow-up included pain severity, urinary symptoms, subjective improvement, and adverse events. We had 22 patients, mostly females, and all patients were refractory to multimodal medical therapies. Even half of our patients had already received fulguration in the past. The median follow-up under cyclosporine was 27 months. At their last follow-up, patients reported sustained pain reduction with a median pain score of 0 compared to 8 out of 10 prior to cyclosporine introduction. The median urinary frequency also decreased to 9.5 compared to 20.8 pre-treatment, and nocturia also decreased to 2.3 episodes per night compared to 6 prior to cyclosporine introduction. All those reductions were statistically significant. Patients reported to be 90% improved compared to baseline via the SIR, and PGI was of 1, meaning that patients perceived themselves to be very much better. 3 patients needed additional procedures with either triamcinolone or fulguration at their follow-up of 3, 13, and 33 months respectively. Concerning adverse events, no patients presented elevation in liver enzymes. Significant overall decrease in renal function was observed, however, remained clinically not significant, and improvement was observed following a cyclosporine dose reduction. De novo or worsening in arterial hypertension was observed in 3 patients and was well controlled with the adjustment of hypertension medication. Cyclosporine dose was decreased to 1.2 mg per kilogram or less in 12 patients due to a long-term relief, creatinine increase, or platelet decrease. Only 1 patient discontinued cyclosporine due to abdominal pain of uncertain origin. Studies assessing the long-term benefit of fulguration showed that repeated fulgurations were required after approximately a year in the vast majority of patients because of symptom recurrence. Meanwhile, in our study, only 3 patients received repeated procedures, while 86% of our cohort remained relieved throughout the follow-up of 27 months. Therefore, the addition of cyclosporine to fulguration seems to procure a sustained positive response thus far. Even with the low dose of 1.5 milligram compared to 2 or 3 milligram per kilogram used in other studies, our cohort still presented decline in renal function. Even if not clinically significant, dose reduction was conducted and improvement was observed. Hence, aiming at the lowest effective dose could potentially maintain symptom relief while minimizing impact on renal function. Previous studies have reported symptom recurrence within a few months following cyclosporine discontinuation. Therefore, a long-term maintenance therapy might be required for sustainable benefits following fulguration. In conclusion, oral cyclosporine seems to allow a sustained long-term response following HL fulguration by alleviating pain, decreasing urinary symptoms, and procuring great subjective improvement. The low dose of 1.5 mg per kilogram appears to have limited adverse events, while still preventing the need for repeated fulguration. As HL is a rare disease, multi-center trials could provide more definitive results by allowing a larger sample size. Thank you very much for your attention, and I will gladly answer any of your questions. Thank you.